Howdy, y'all. It's Dr. Jarvis, and I want to give you an overview about this new thing called DSI, or delayed sequence intubation. And I want to contrast that to what we've been doing in the past, which is RSI, or rapid sequence intubation. So, in contrast to the rapid sequence intubation, DSI is delayed sequence intubation, where we are taking our time during the process and we're doing it specifically so that we can adequately pre-oxygenate the patient. The reason we're doing this is we took a look at some of our data and we found out that patients were becoming hypoxic during our intubation attempts. And unfortunately, in some cases, we found that we were not so much doing RSI as RSD. And there were some consequences to that we weren't really all that pleased with. So that's the reason that we're adopting this rapid sequence or delayed sequence intubation, I should say. So I really want to thank Dr. Scott Weingart for these concepts. Dr. Weingart is an emergency physician and a critical care physician in New York. He puts out a podcast called IMCRIT. You can find it on iTunes or you can find it at imcrit.org. He also has a very informative website. He puts out a lot of really good medical education. I try to listen to his podcast every time one comes out. If you've not heard of Dr. Weingart or not heard his podcast, I'd really recommend you do it. He has some good stuff. Well, he wrote an article called No DSAT with Dr. Levitan, and Dr. Rich Levitan has done an awful lot for emergency airway management. He has a great textbook out. He's someone I've learned an awful lot from, and the two of them together were like an airway powerhouse. And they put out this article called No DSAT that is talking about how to prevent desaturations. And then he expanded on that a little bit with this delayed sequence intubation concept. And you can actually see a lot of the resources that he's put together on this by going to his website and looking at his DSI page. And you can see it at imcrit.org/DSI. So thank you very much, Dr. Weingart. Let's cover why we want to intubate in the first place. So usually you can break this down into two broad categories. You either want to intubate to protect the airway or because the patient has respiratory failure or impending respiratory failure. So from an airway protection standpoint, this is probably one of the better ways or reasons to intubate because the ET tube does a better job of protecting the trachea and isolating the lungs from secretions and blood and other foreign bodies than do supraglottics, although supraglottics, there's some evidence that they do a decent job of this. But airway protection really, I think, is the best reason to be intubating. And it's certainly, I think, intubation is considered the gold standard for airway protection, both out of the hospital and in the hospital. Respiratory failure, the main reason I want to point this out is we typically think that hypoxic respiratory failure is about the only type of failure there is, and that the only thing to do for that is intubate. So we're actually wrong on both counts. So the ET tube, there's actually nothing magic about an endotracheal tube to helping with hypoxia. We need to be much better at getting the patient sats up with non-tube approaches. So we need to be better at using the bag valve mask, using our FiO2, and using our PEEP, and then other adjuncts, nasal trumpets or oral airways, than we are right now. But I think we all intrinsically understand what hypoxic respiratory failure is. But I also want to point out that there is hypercapnic respiratory failure, and we see this frequently with patients who have obstructive lung diseases that are retaining CO2. So as their CO2 levels get higher and higher and higher, they become obtunded. Their mental status drops, and then they can no longer protect the airway. So also be thinking about hypercapnic respiratory failure. So why should we not intubate? What are the arguments against intubation, particularly in the field? And really the biggest of those says that there is no evidence that intubation in the field improves outcomes. Now, I will tell you there is also no evidence that intubation in the hospital improves outcomes because nobody would think to study it. And a classic example of this concept of the lack of evidence not necessarily being the same thing as evidence of harm is a paper the British Medical Journal published as an April Fool's joke, and it talked about the evidence-based medicine literature discussing the efficacy of parachutes when jumping out of planes, and their conclusion was that there is no evidence-based medicine support, no EBM support for the use of parachutes when jumping out of an airplane because there have been no randomized controlled trials. Obviously, that's kind of ludicrous. We do some things because they make sense and we're not able to actually trial them. So there's no IRB in the world that would allow us to say we have a patient in the hospital that we think needs to be intubated and we're not going to intubate them. Studies have been done in the field, though, with EMS intubation in two broad categories, cardiac arrest and traumatic brain injury. And most of these started initially because the medics in the field weren't doing intubation, and then they added intubation. So they were able to say, was there a difference before and after? Whereas in the hospital, there was never a before. So I want to go over some of the evidence about cardiac arrest and traumatic brain injuries, because one of the main reasons we're doing this has to do with the harm that has been found with intubating traumatic brain injuries. And I want to suggest that it's not about the ET tube, it's about what we do, how we get the ET tube in place, and what we do afterwards. So what do we know about cardiac arrest? A couple things, and I'm going to go through this literature pretty quickly. We know that hyperventilation is very common. When you look at objective data, either through monitor files or videos of resuscitations, we know that despite saying we should be ventilating around 10 times a minute, the average ventilatory rate in cardiac arrest is really closer to 40 to 60. So it's incredibly common. It's very common whether it is an EMT doing this, or a paramedic, or a nurse, or a respiratory therapist, or a physician. It's common across all specialties. It's just human nature. So why is that necessarily bad? We know that when we switch to a positive pressure ventilation system, meaning instead of the negative pressure system we use when we're spontaneously breathing, where we decrease interthoracic pressure by increasing the volume in our chest, that creates a pressure differential between the inside of the lungs and the outside atmosphere. So when we decrease the pressure in our lungs, air moves in through our patent airways and we inhale. That's how negative pressure works. What we're talking about here is a positive pressure system where we are increasing the atmospheric pressure by squeezing a bag. We know that when we do that, we actually increase interthoracic pressure. Now, when you increase interthoracic pressure, that also changes the pressure gradient or pressure differential in the vasculature between the right ventricle and your systemic circulation. So normally systemic return or preload, the amount of blood that's in the right side of the heart before contraction, is determined by a pressure differential between the systemic circulation and the heart. As we inspire normally with a negative pressure system, again we decrease interthoracic pressure. That drops the pressure in the heart compared to the pressure in the systemic circulation, and blood comes up the venous system and returns. When we artificially increase interthoracic pressure, that decreases that venous return. When you decrease venous return, that decreases the amount of blood that is available to the left ventricle to be pushed out into the circulatory system. So when you increase interthoracic pressure, you decrease venous return, which decreases cardiac output, and we have seen that that increases mortality. So that's a problem. We've also seen several papers now which confirm this concept of MICR, or minimally interrupted cardiocerebral resuscitation. And this is the approach that we're using in the field now, where for patients with cardiac etiology, we do not do any active ventilation for the first 6 minutes of the arrest. We put an oral or nasopharyngeal airway in, and apply a source of high concentration oxygen and do apneic oxygenation early on. The reason we are doing that is to avoid these increases in intrathoracic pressure and therefore increase our venous return and not decrease it. When this approach to CPR has been studied, survival has tripled. So that's a very good thing. If you look at, there have been a lot of studies, now these were non-randomized studies, they show that survival in cardiac arrest decreases with intubation. Now I will tell you that there are some problems with these studies. These are a couple of them. There was a study done on the CARES registry, the Cardiac Arrest Registry to Enhance Survival. It's a big North American database where people put up information on their cardiac arrest. And what they show is survival when there is a BLS airway only, so no advanced intervention. That survival is much, much greater than if there's any advanced airway. Now, if you break that down, which they did, and they said, okay, let's only look at the patients who had an advanced airway, it turns out intubation does better than supraglottic airways. And then there was a reanalysis of the ROC primed study. And the ROC studies, if you'll remember, are the big research outcomes consortium, big North American studies, multi-center studies that have looked at a huge number of things. This was one of them where they were looking at the among other things, the ITD or impedance threshold device. Again, they looked only at people who got some advanced airway, and they found that survival improved with intubation over supraglottics. But in every case they've looked at, the survival was better if there was no airway than if there was an airway. Now, I think this is a little biased because the patients that are most likely to succeed or survive cardiac arrest are also the ones who are most likely not to get an advanced airway. Those are the people who, I think most of us have seen the picture of the volleyball player who collapsed from sudden cardiac death in the middle of a game. Someone rushed over immediately, began doing CPR, they had an AED, they shocked her. She woke up, regained consciousness, had ROSC, before anybody had time to put an advanced airway in. As opposed to the patient who has been down for a while, we begin doing CPR, multiple shocks, multiple rounds of drugs, and time to intubate. Those are different populations of patients. So just a little caveat about that. I bring it up primarily because this is a pet peeve of mine and I want to make this case. So this is just another way of looking at the effect advanced airways have on outcomes from cardiac arrest. And I'll just leave that up there, but this is essentially showing what we had seen before. Let's switch to traumatic brain injury now, and this is something that I really want us to understand. Right off the bat, we know that hyperventilation and hypoxia in traumatic brain injury more than doubled mortality. So just to give you an idea on this, if I walk up and hit somebody upside the head with a 2x4, I give them a traumatic brain injury, and let's say I hit them hard enough to make their baseline mortality now 15%. So there's a 15% chance that they're going to die. Now, their oxygen sat before we come along to help is 96. We begin intubating them, and their oxygen sat drops for a short period of time to 85, and then goes back up to 100% after the intubation. That one episode of hypoxia now changes their mortality from 15% to 30%. One single episode of hypoxia can double mortality in traumatic brain injuries. This is a really, really big deal. So I think we frequently don't truly estimate how big of a deal this is, but when we allow our patients to become hypoxic, we are increasing their mortality. We are doing harm, and that can't happen. The literature also points out that hypoxia during RSI is very common. Not surprisingly, when I'm going to show you our own data, I'll tell you that it's common here too. And it's often undetected. So we're going to talk a little bit more about this, but basically when medics did an intubation, they had no idea the patient became hypoxic during that intubation until they went back after the fact and looked at the data. We also know hyperventilation after RSI is very common. We initially thought using end-tidal CO2 would make that go away. We would just say bag to a certain end-tidal CO2. It doesn't happen. People continue to hyperventilate. incredibly frustrating is putting a metronome light on that says just bag with this light still doesn't fix the problem because hyperventilation occurs even with the light. And again, it occurs at all skill levels. It happens at the ECA level. It happens at the physician level. It's human nature, and that's, I think, the thing that we have to understand. Rather than saying these are bad providers, we have to understand this is human nature, and we need to redesign the system so that this doesn't happen. To give you a real quick overview of why I think it's happening, I blame 100% our adrenal glands. So our adrenal glands are the ones that secrete epinephrine, or adrenaline. And they do this in response to stress. And I think we all know that some of the effects of adrenaline or epinephrine is that we increase our heart rate, we increase our awareness, but above a certain point we get very jittery. We find it's difficult to focus on very many things at once. So anytime we're in a high stress situation, our adrenal glands kick into overdrive and our perception of time and speed gets altered. So I think that we're actually incapable of ventilating without paying an awful lot of attention, and I just don't think that it is reasonable to expect humans to do that. We need to come up with additional systems. The reason I bring it up here is just to let you know that this is happening. All right, so what do we know about RSIs, so intubations with brain injury? We know that RSI done by ground medics increased mortality, and RSI done by air medics decreased mortality. Now, I will tell you that air systems very, very rarely do RSI or intubate patients when they're in the air. This is something they do on the ground before they take off. So the environment really isn't any different between air and ground. This paper specifically says the distinction is in intubation experience. The medics who are in the air systems have an opportunity to intubate more often than do the ground medics. So it's really a function of experience and opportunity to perform intubation. There was a similar system that said intubations done by emergency physicians in the field decreased mortality. So these were done not in U.S. systems, but in European systems where there were physicians. And they showed that those folks doing these for TBI decreased mortality. And then again, there was another paper that looked at inexperienced versus experienced and saw that there is a difference. So this is the reason that I don't believe every single medic in an entire system should be intubating. There are only so many intubations to go around, and we need to maximize the experience each of our medics has.